So I'm Chris Palmer. I'm a psychiatrist, and I'm going to be talking with you about the metabolic theory of mental illness. I really want to thank Emily and all for inviting me, Greg. How many, just quick show of hands, like how many people have heard me give this type of a lecture before? Good. No, I'm really glad. So I'm sorry to the people who've heard it, but that's what I usually assume people have not heard it. And at some point I'll give like the advanced course, but we're just gonna walk through. So I have no financial disclosures related to the work that I do other than I wrote a book and I get royalties for that book. So in case you didn't know, we have a mental health crisis. Prior to the pandemic, about 1 billion people on the planet suffered from a mental disorder. That represents about 13% of the world's population. Rates in the United States are even higher. 1 in 5 people have a mental disorder in any given year. About 50% of Americans will meet criteria for a mental illness at some point or another during their life. But because of the pandemic, rates are even higher now. Mental disorders are one of the leading causes of disease burden and disability worldwide. Yes, access to care is sometimes problematic, but even some people getting the best care, our treatments fail to work. And there's this curious thing. The rates of mental illness across a wide range of diagnostic categories have been increasing for decades. Rates of autism have quadrupled in the last 24 years. The rates of ADHD have tripled since 2010, but these statistics are actually not the most recent. There's been an acceleration in the rates of diagnosis, and in case you didn't know, we have had an Adderall shortage the last few years. The rates of depression last year reached an all-time ever recorded high, both in terms of current prevalence and lifetime prevalence. This is a worldwide phenomenon. The rates of eating disorders in the United Kingdom, hospitalization for eating disorders, up more than 5-fold. These are the people who are too thin. These are the people who are starving themselves to death. You do not get admitted to the hospital for binge eating disorder. You get admitted to the hospital for starvation. And overdose deaths in the United States, up over 5-fold. So what are we doing? What are we doing about this crisis? Well, we have treatments. We have a plethora of medications, psychotherapies, hospitalizations, group therapies, electroconvulsive therapy, transcranial magnetic stimulation, ketamine, psychedelics, addiction recovery programs, eating disorder programs. I am a Harvard Medical School psychiatrist, been there for almost 30 years. I want to say these treatments, in fact, do work. They really work for some people. They save millions of lives every year. I am not here to bash the treatments, but unfortunately, even if you're getting the best treatment possible, they often don't work. Treatment resistance is very common, affecting anywhere from 20, this is from one paper. They could not narrow it down more specifically than this. 20 to 60% of people diagnosed with psychiatric disorders have treatment resistance. Why such a ridiculously wide range? Because it really depends on what diagnosis are you talking about, how long are we following them for, what is the follow-up methodology? Are we talking about lasting remission? Are we talking, if they get a remission for 2 months, but then it comes back, is that treatment resistant? Or do we count that as a response because they responded for 2 months? The reality is this is a crisis. This is a massive crisis taking a massive human toll. And it begs the question, why can't we do better? And I would argue we can't do better because our field has been unable to answer two fairly simple questions. And the first question is, well, what exactly, Dr. Palmer, causes mental illness? Can't tell you how many times I've been asked this. If you ask the leading psychiatrists and neuroscientists in the world, they will tell you. If you find an honest one, they will tell you, no one knows. It's just too complicated. All we know are risk factors. And we talk about the biopsychosocial model. So this is what you're going to hear. You're going to hear it's neurotransmitters, but genetics and hormones, but also trauma and stress and childhood adversity, loneliness. Loneliness is the big thing for the Surgeon General right now. Loneliness. If we tackle loneliness, that will tackle our mental health epidemic. How do all of these things fit together? Well, Dr. Palmer, it's just too complicated. No one knows. The second common sense question that our field has been unable to answer is, well, what exactly is mental illness? So on the surface, this seems like a ridiculous and rhetorical question because we have DSM-5-TR, which has all of these household labels that all of you know, things like schizophrenia, depression, bipolar disorder, alcohol use disorder, aka alcoholism, anorexia nervosa, OCD. And on the surface, most people assume that these are valid disease constructs. They are household words. But there are three problems with DSM constructs: heterogeneity, comorbidity, and a lack of validity. So heterogeneity says that two people with the same diagnostic label can have wildly different symptoms from each other. One person with depression can be overeating, oversleeping, have no suicidal thoughts. Another one can be undersleeping, undereating, losing weight, and have plagued with suicidal thoughts. And I could go on with the other symptoms, but they can have wildly different symptoms, sometimes polar opposite symptoms, and we give them the same label. Two people with autism. One, I say this a lot, but so forgive me if you've heard this, but you can have a kid whose parents painfully have to put this child in a group home because they cannot safely care for him at home. He bangs his head against the wall to the point of bleeding. He has seizures and he has profound cognitive impairment. And if you say, what is wrong with this child? They will say, he's autistic. And we have billionaire businessmen that we see in the news every day with this exact same diagnostic label. Comorbidity says that if you have one mental disorder, you're more likely to have another. So on average, population studies, if you qualify for one mental disorder, there's a 50% chance you qualify for more than one. But if you're actually seeking treatment, mental health treatment, on average, people have 3 to 4 different diagnoses. So that means that if you are being treated for schizophrenia, there's a good likelihood you also have OCD and maybe a substance use disorder. But that means if you've got anorexia nervosa, you might also be more likely to have OCD and a substance use disorder. But if you have major depressive disorder, you might be more likely to have OCD and a substance use disorder. Now, on the surface, schizophrenia, depression, and anorexia nervosa are wildly different things. But if you look at real humans who have these things, they overlap on 2 out of 3 of their brain disorders. How does that work? So this is nothing new. If you haven't heard this before, this is not a heresy. Tom Insel at the NIMH figured out long ago, decades ago, we are never going to make progress as a field as long as we cling to these failed labels. It's time to move on. And under his leadership, the NIMH developed the research domain criteria, which is a trans-diagnostic model of diagnosing mental disorders. Now there are competing models, hierarchical taxonomy of psychopathology. These models get so ridiculously complicated fast because there are hundreds of different mental health symptoms, and you can have no symptoms, mild symptoms, moderate symptoms, severe symptoms. Some of them can be considered normal and others can be considered abnormal. And that's why the field hasn't even adopted these things. They're like, that's just too complicated for us, so we're just gonna stick with schizophrenia and depression for now. Thank you very much. So all of this says, everything that I've just said right now, says the mental health field is an effing mess. And it's tragic because people are dying, people are suffering. I will bet money most of you or all of you know somebody. A nephew, a niece, a son, a daughter, the neighbor's kid, your coworker's kid. It's not funny. The shocking thing is that there are several lines of research that suggest this problem might actually be solvable. And the shocking thing is that these lines of evidence all seem to suggest that mental disorders share a common pathophysiology. So this was first proposed in 2012 by Leahy, who just looked at internalizing and externalizing mental disorders, which is a subclass of different disorders. And they looked at everything they could find, neuroimaging studies, genetic studies, like risk factors, abuse, how does that play in? Substance abuse, how does that play in? And they put it through mathematical models. And the mathematical models said they all seem to converge in some way. There appears to be a common factor that leads to these mental disorders. In 2018, Caspi and Moffat expanded on this model and looked at every label in DSM, and they found the same conclusion. And then just last year, Brandt et al. Said, whoa, it's not just these mental disorders. There are a lot of physical health conditions that also seem to share this common pathophysiology. Now, these are mathematical models looking at risk factors, genetics, and other things. The mathematical models could not tell us what the common pathway is. So there are many in our field who think this cannot be true. It's just too unimaginable. There can't be something that unifies all of the mental disorders. There are others who very strongly believe they know what it is. The one you've probably heard the most, it's trauma. It's trauma. Trauma causes all mental illness. And if you're familiar with Gabor Mate and others, this is precisely what they say. Doesn't matter what symptoms you've got, doesn't matter what label you've got, trauma is the unifying cause of all mental illness. So there's lots of controversy in the field around this. So what I have boldly gone out on a limb and suggested is, no, it's not trauma. Trauma can play a role for some people, but that it is in fact what we call metabolism. That mental disorders are metabolic disorders impacting the brain. And why would I say this? Because every known risk factor for mental illness can be tied directly to metabolism. That if you understand cell biology, you will understand that metabolic dysfunction in cells can actually explain why the brain would show what it shows in all of the people that we see with mental disorders. It's a way to integrate the biopsychosocial risk factors, and once and for all, it's a way to stop with this artificial separation between mental health and physical health. So, for the people who haven't heard any of this, I just want to read something from Albert Einstein. Creating a new theory is not like destroying an old barn and erecting a skyscraper in its place. It is rather like climbing a mountain, gaining new and wider views, discovering unexpected connections between our starting point and its rich environment. But the point from which we started out still exists and can be seen, although it appears smaller and forms a tiny part of our broad view gained by the mastery of the obstacles on our adventurous way up. Why do I read this? What Einstein meant is that his theory did not replace the theory of gravity. It included and incorporated and integrated the theory of gravity with the theory of momentum and other theories. His theory was not replacing the existing theories and laws of physics. It was integrating and unifying them. And that is what I am proposing in the mental health field. So trauma does play a role. Neurotransmitters do play a role. This is a way to integrate it. So let me just share with you a quick tour now of some of the lines of evidence. There are actually numerous lines of evidence. I wrote a whole book, and I could have written probably 10 more books with all sorts of arguments and studies to support this. But we're going to start with correlations. Now, correlations don't equal causation. Correlational evidence is not the strongest. But when you see strong bidirectional correlations, you need to at least consider the possibility of a common pathophysiology. And in fact, mental disorders share strong bidirectional relationships with all of the disorders, diseases on the right-hand side of this screen: obesity, diabetes, cardiovascular disease, and Alzheimer's disease, which people largely accept as metabolic. So what do I mean when I say bidirectional? In case you don't know, means if I go to McLean Hospital and look at a select group of mental health patients, they are more likely to currently have or in the future have all of the disorders on the right-hand side of the screen. But if I go to a Weight Watchers group and look at a group of obese people, they're more likely to have mental illness. If I go to a cardiovascular disease unit, they're more likely to have mental illness. Likewise, if I go to a nursing home, those people are more likely to have symptoms of mental illness. Let me walk you through just a couple of statistics to share this. If you have a chronic mental disorder, 2 to 3 times the rates of obesity and diabetes, anywhere from 50% to 350%, more likely to have premature cardiovascular disease. If you have chronic depression, 2 to 3 times the rates of Alzheimer's disease. If you have schizophrenia and live to the relatively young age of 66, you have a 20-fold increased risk, 2,000% increased risk of developing dementia on top of your schizophrenia. What about the other way around? If you have obesity, 50% to 350% more likely to develop a wide range of mental disorders after your obesity. You're obese first, and then you're more likely to develop depression, anxiety disorders, personality disorders, eating disorders, psychotic disorders, and some, not all, substance use disorders. The obese people are lucky in that they have lower rates of like alcoholism and things, but they have high rates of nicotine use disorder. That's their saving grace. Diabetes, 2 to 3 times the rates of mental illness. Cardiovascular disease, 3 to 5 times the rates of mental illness. Alzheimer's disease, one study says 97% of patients with Alzheimer's disease will have symptoms of mental illness. They will have depression, anxiety, agitation, OCD, ruminations, insomnia. 40 to 50% will have hallucinations and delusions. Hallucinations and delusions, these are the hallmark symptoms of what we call schizophrenia. So I want you to think about 2 of the statistics I just shared with you. If you have schizophrenia, you have a 20-fold increased risk of developing premature dementia. If you have dementia, you have essentially a 50-fold increased risk of developing the hallmark symptoms of what we call schizophrenia. We really cannot talk about the root causes of any of these disorders without looking at how they connect. And in fact, metabolism is more than just obesity, diabetes, cardiovascular disease. You can be thin and metabolically unhealthy. I want to make that clear. You can be anorexic and metabolically unhealthy. And in fact, if you get diagnosed with a mental disorder, this is a population study of over 6 million people. If you first get diagnosed with a mental disorder, what is your risk of subsequent medical disorder diagnosis? All of the metabolic ones are here. Wide range of physical health conditions. And in fact, this large population study, not really a population study, it was a cohort study where they looked at about 170,000 adults, half who had neuropsychiatric disorders, half who were healthy controls. They did brain scans, blood work, all sorts of stuff on these people. And then they analyzed all this data, looking for how can we separate these mentally ill people from the other ones. And what they concluded, poor body health, particularly of the metabolic, hepatic, and immune systems, was a more marked manifestation of mental illness than any brain changes that could be measured or detected. In many ways, this is nothing new. We have long known that people with chronic mental disorders die early deaths, losing anywhere from 7 to 30 years, depending on what your diagnosis is, what population you're studying. But in fact, a study published 5 years ago now in Lancet, it's not just depression and schizophrenia and bipolar, it's all of them. All of the DSM-5 labels, every single one of them, is associated with premature mortality. On average, men are losing 10 years of life. This is on average, 10 years of life. That's a lot. Women are losing 7 years of life. That's even a lot, but lucky women. What are these mentally ill people dying of? Everybody thinks suicide. Oh, they're just crazy and killing themselves. Yes, they are killing themselves at a much higher rate than the general population. And yes, that plays a role in these statistics. That is undeniable. But the primary cause of death in the mentally ill are heart attacks and strokes, just 7 to 10 years younger than everyone else. Why? This has not gone unnoticed. The World Health Organization put together a task force. They came up with 3 conclusions. Factors related to the individual's behavior. That means the mentally ill overeat and underexercise. Or maybe it's medication side effects. We'll throw them the bone. It's medication side effects, maybe. Problems at the health system level. The mentally ill don't go to their primary care docs and take statins like good patients should. Wider societal issues. The mentally ill are more likely to be poor and unemployed. Poor, unemployed people are more likely to die early deaths. Maybe that's it. The reality is that I think these explanations and the common perception of these explanations is really about blaming the victim. What we're really saying is that the mentally ill are lazy slobs. They overeat, they underexercise, they don't work, and that's why they are the way they are. They're getting what they're asking for. They probably smoke and drink too. Those are mental disorders, so they definitely are more likely to smoke and drink. So they're just getting what they deserve. It's choices. Lack of willpower, laziness, lack of discipline. What I am here to assert is that these are actually symptoms of metabolic dysfunction. That when you are metabolically compromised, you will be hungry when you shouldn't be. When you are metabolically compromised, you will be fatigued and lethargic in a way that probably some people in this room can't imagine. When you are metabolically compromised, your brain will actually not work right. You won't be able to hold a job. You won't be able to think straight. You won't be able to remember things. You won't have the motivation. You won't have the executive function to show up at work on time every day. And in fact, this is nothing new. This theory is not created out of thin air. This theory is about integrating over a century of science. In the 1930s, Researchers discovered abnormalities in lactate metabolism and glucose metabolism in people with bipolar disorder and schizophrenia. We've been doing these neuroimaging studies for decades. PET scans, SPECT scans, functional MRI. Guess what all of those scans are measuring? They're measuring brain metabolism. The diagnoses are widespread: depression, anxiety, PTSD, schizophrenia, bipolar, anorexia, alcohol use disorder. Well, Dr. Palmer, what's the test that I should do for metabolic dysfunction? There isn't one. There's a wide range of tests. They can be different in different people, but when we look at groups of patients with mental disorders compared to healthy controls, we see differences in the levels of lactate, glucose metabolism, the ATP to ADP ratio, reactive oxygen species, redox markers, levels of NAD to NADH, inflammatory cytokines, cortisol, brain insulin, mitochondrial function. I'll come back to that. I don't need you to understand the details of what the hell did you just say? All I need you to understand is that metabolism is super complicated and we don't have one single biomarker for metabolic dysfunction. There is not one biomarker. Now, some people really have a hard time with this. They're like, Chris, come on. I see my patients right in front of me. I put them on the pills. They're clearly overeating. They're gaining lots of weight. They're smoking like a chimney. They're not exercising. They're not doing any of this. That's why they're dying. This study suggests maybe it's not so simple. They followed children, innocent little children from the ages of 1 to 24. Those who had the highest levels of insulin resistance beginning at age 9 had a 5-fold increased risk for having a psychosis at-risk mental state by the time they turned 24, and they were 3 times more likely, 300% more likely to be diagnosed with schizophrenia or bipolar disorder. The kids who gained the most, they were also more likely, these insulin-resistant kids were also more likely to develop depression, but it was about 2 to 3 times the rate, but it didn't reach statistical significance in their sample. But the kids who gained the most weight around the time of puberty were 4 times more likely to develop clinical depression by the time they turned 24. So how does this work? People have a hard time with this. People like to think in linear relationships. You eat bad food, that makes you sick, and then you're metabolically unhealthy. I want you to think in terms of what we would call a feedback loop. Because this is a cycle. This is a cycle between what we call mental health and metabolic health. Now, most people think of mental health in simplistic terms. Mental health is either a chemical imbalance, that's neurotransmitters. Why do they think of it that way? Because the treatment's a pill. That's what we hear. You got a chemical imbalance, you need your pill. Or it's stress, adverse childhood events, trauma, loneliness, whatever. The treatment for that, that's psychotherapy. So that's mental health in a nutshell. Pills, psychotherapy, because it's either neurotransmitter imbalances or it's stress and trauma. What causes obesity, diabetes, cardiovascular disease? Well, Dr. Palmer, that's an easy one too. Diet and exercise. If everybody just did the right diet and did the right exercise plan, I know some CrossFitters here who are like, no, that's true. And I have a different interpretation of why CrossFit works. Because it's not just eat less calories. It really isn't. I think you're changing metabolism. But there is this simplistic notion in society that if you are obese, if you are diabetic, it's a diet and exercise problem. And in fact, neither of these is so simple. We've long known that genetics and epigenetics play a role, hormones, inflammation, sleep, the gut microbiome. What I'm here to say is it's all interconnected. And that means that if you have trauma and loneliness as a child, you are more likely to develop obesity and type 2 diabetes as an adult. I'm not wildly speculating. There's this whole field of study. It's called social determinants of health. Hundreds of thousands, if not millions of people are subjects in those studies. What no one talks about almost is, does diet and exercise play a role in mental illness? So I'm saying metabolism, metabolic, what does that mean? A lot of time, people like simple things. They like simple definitions. Metabolism, what is it? It's burning calories, Dr. Palmer. Burning calories. Well, maybe it's that metabolic syndrome thingy, you know, the blood pressure and the glucose. Insulin resistance, that's what it is. It's insulin resistance. Insulin resistance is metabolism. No, neither. Both are true, and neither one is anywhere near sufficient. So a simple definition would be, it's the process that all living organisms use to convert food into energy, building blocks used to maintain or grow cells, and it also involves the management of waste products. Metabolism is extraordinarily complex. It's kind of sort of represented by this somewhat simplistic metabolic pathway diagram, because it's actually much more complicated than that. Metabolism is fundamental to the definition of living organisms. In fact, the cessation of metabolism is the definition of death. There are no exceptions to that rule. Death is defined by the cessation of metabolism. If an organism cannot do metabolism on its own, like a virus, many biologists say that is not an independent living organism. The definition of a living organism requires the organism to be capable of metabolism on its own. So from that perspective, well, Dr. Palmer, if you're using that kind of a definition, like it's everything in biology, and you're saying that mental illness is somehow or another related to it, yeah, that's not really that helpful. It's not really helpful. It's not going to do a lot for us. But let's keep going. Let's ask another question. Well, what controls metabolism? And we are led to these tiny things in our cells called mitochondria. Now, for any of you who know mitochondria from biology class, you probably heard that they are the powerhouse of the cell. Cutting-edge research over the last 25 years completely decimates this stupid and simplistic definition. Yes, they are powerhouses, but they are so much more. They, I would argue, are the master regulators of metabolism. There are hundreds or thousands of them in each cell. They form communities in the cell. They move around. They fuse with each other. They bud off from each other. They are involved in numerous cellular processes. Now, if you start to do a deep dive into the science of mitochondria, it gets overwhelming quickly. And if you asked some blinded mitochondrial researchers even, describe mitochondria to me, it would be like asking blind scientists to describe the elephant to you. They will describe different things. And if you do a deeper dive, they have different cell-dependent phenotypes, features, activities, functions, and behaviors. It gets ridiculously complicated fast. Mitochondria are a universe unto themselves within the cell, and it's a universe that we are only scratching the surface on. We know the tip of the iceberg. But I can tell you we know enough to be able to say that they are the common pathway to neuropsychiatric disorders. That mitochondria actually control the production, synthesis, and release of some key neurotransmitters, including GABA, glutamate, serotonin, dopamine, and others. But these neurotransmitters impact their function in the receiving cells. Mitochondria are actually the primary creators of signals that control epigenetics from the cell nucleus. But of course, genes from the cell nucleus influence them. They are the master regulators of inflammation, turning it both on and off, and yet inflammation and inflammatory biomarkers impact their function. The gut microbiome plays a role. Diet and exercise do. So what you eat affects mitochondrial function, but mitochondrial function in very specific brain regions will determine whether you are hungry or full, or full. And researchers can manipulate mitochondria in these brain cells. That's all they're doing, manipulating mitochondria in the brain cells, and animals will become obese as a result. Mitochondria determine whether you have the energy to exercise. But exercise improves their function if done appropriately. Trauma, adverse childhood events, stress impact their function. Drugs and alcohol do, sleep does, hormones do. And in fact, mitochondria control the first step in some hormones that you may have heard of. They control the first step in the synthesis of cortisol, estrogen, testosterone, and progesterone, known to play a role in both mental health and metabolic health. Now, when I first published this, I really did feel like I was out on a limb, and I was like, everybody's gonna laugh at me. Fortunately, there are other people already jumping on board. These researchers cited me, thankfully, and said, yeah, no, it's mitochondria. Oh my God, eureka. They are the way to unify all of the biopsychosocial risk factors. A lot of people get hung up on that. You're saying it's all biology, Chris. What about stress and trauma? Stress and trauma are directly influencing metabolism through anticipatory responses. But if stress and trauma are prolonged, it results in maladaptive outcomes, and these maladaptive outcomes are all converging on mitochondrial dysfunction. That the stress and trauma, if you will, if you want a simple way to think about it, it can burn out mitochondria. And again, this is nothing new. This is about integrating over a century of science. In the 1800s, diabetes, a metabolic disorder, is a disease that often shows itself in families in which insanity prevails. Before we had antipsychotics that make people fat and diabetic. Within 10 years of the discovery of the molecule insulin, we were injecting it into the mentally ill. It was the most widely used treatment in the Western world for severe mental illness. I mentioned the abnormalities in lactate and glucose metabolism in bipolar and schizophrenia, 1930s. It's almost 100 years ago. Mitochondrial theory of autism, 1985. All of the imaging studies. The mitochondrial theory of bipolar disorder, first proposed in 2000. And since then, there has been an explosion, an exponential explosion. Neuroscientists, psychiatrists, biotech companies, there are many biotech companies already in hot pursuit of this field. So a new theory opens up entirely new doors. It has to have predictive value. And time will tell. Does it have predictive value? I can tell you in the last 5 years since I've been doing this work, I can pretty accurately predict a lot of research that's already been done that I just didn't know about. I was like, wait, if my theory is true, marijuana somehow has to be connected to mitochondria and cause mitochondrial dysfunction. But that doesn't make sense. I've never even been taught that. I've never heard that. I Google it. Fuck, it's right there. It's like, it's already been published. People have already proven that. Oh my God. That's why people get psychotic on marijuana. Gee, so that's one example. I've gone through hundreds of examples. But again, time will tell. Other researchers are actively pursuing this. But as a psychiatrist, I hope you don't mind that I swore a little bit. I'm sorry, Emily, you've got kids. Oh my God. Oh well. This is a small audience. Usually I don't swear in front of audiences. This is small. You guys are friends. In addition to science, I think that, I have always been a clinician. And I really want to know, what can we do for patients right in front of me today? What can I do? How could this theory be helpful? First and foremost, I want to propose that we need a new model of healthcare, one that integrates metabolic health, mental health, and longevity and healthy aging. And some will look at this and say, well, Chris, you've got to be joking. We must already be doing this. We have to be doing this. If you go to a mental health professional, there's a good chance they're going to give you pills that make you overweight, that make you diabetic, that increase your risk for cardiovascular disease, just the pills alone. These pills shorten lifespan, especially among the elderly. Now, I'm not being a paranoid conspiracy theorist. If you believe in the FDA, this is all written right on the package insert. Just read the package insert. And if you know anyone who's ever taken these pills, it's plain as day. So we don't currently offer integrated human health care. So what can we do? Now, first and foremost, I'm going to say, I don't want to throw the baby out with the bathwater. Treatments do work. They really do save lives. We've got to keep using them for right now. The system will not change immediately. Some of the medications can be wonderful, and I'll give you some examples of how and why that makes sense. So we're going to use all of these treatments, but the things we almost never talk about in the mental health field are diet, nutrition, vitamins, supplements, exercise in a real way. Like, am I going to send you to CrossFit for your anxiety disorder, or am I going to put you on Prozac? CrossFit. Yeah, no, we should, but that doesn't happen right now. So, you know, in terms of the predictive model, this was one of the other predictive models, because I'm like, wait, the medications do work. So how does that make sense? And it turns out that almost all, if not all, psychotropic medications can be tied directly or indirectly to effects on metabolism and mitochondria. So this group of researchers tried to figure out, how the hell does Prozac work? In case you didn't know, it's not a serotonin imbalance in the brain. That's what everybody's heard. It's been proven wrong. We have 20 years of evidence. Neuroscientists will tell you we can't find this serotonin imbalance. Now, that doesn't mean that Prozac doesn't work. It just means that our explanation for why Prozac works is incorrect. So these researchers looked at all of the animal models ever done with Prozac, trying to figure out, then what is it doing? What is it doing? How does it work? And these are research studies where they're giving them to mice and rats, seeing an antidepressant effect, then dissecting the brains, analyzing brain tissue, analyzing genetics, upregulation, downregulation of genes. What is Prozac doing? And when they first did this, you see this graph over here. It is wildly complicated. Different brain regions have upregulation or downregulation of different genes, and it's ridiculously complex. And that complexity is the complexity of the brain and the complexity of metabolism. But when the researchers took a step back and said, is there any unifying theme? Is there anything that is coherent across all of these different genetic changes in brain regions? What they found was that across diverse brain regions, integrative omics analysis consistently suggested increased energy metabolism via oxidative phosphorylation and mitochondrial changes. When you take Prozac and it works for your depression, it is working because it is increasing brain energy metabolism through mitochondria. Well, how does Celexa and Lexapro work? This is human trial data. They looked at 136 participants. Now remember, some people take antidepressants and they work, and other people take antidepressants and they don't work at all. So these researchers capitalized on that. They split them in two groups, who got remission and who got no response at all. And then they analyzed the hell out of their blood, trying to figure out what is different about the remitting group from the non-responder group. These findings suggest that mitochondrial energetics are the key to the responders. When an antidepressant works, it is changing mitochondrial energetics. It is improving brain energy metabolism. How does lithium work? Lithium works. If you ask most psychiatrists and neuroscientists today, they will say, yeah, no one knows, it's complicated. That's really what you'll get. They'll say no one knows, it's complicated. And they'll say it's a mood stabilizer, though. It really works. We have decades of data on it. Just trust me. So these researchers, a colleague of mine actually, a couple years ago, looked at everything known about what do we know about lithium? Because we've been studying it for decades, trying to figure out how the hell does it work. So we know a lot about how it works, but nobody ever put it together. And Ian Campbell and colleagues put it together, and it all converges on what is called the insulin signaling pathway, which ultimately converges on these tiny things in our cells called mitochondria. Now, the problem is that, so I've just given you some examples of where psychotropic medications can sometimes enhance brain energy metabolism. That's a good thing. And that helps us understand why they would work for some people and why some people will cling to them for their life and never let them go. And I'm not here to take anyone's Prozac away from them. If they are doing well on Prozac and thriving on it, keep taking it. However, you probably already have figured out that, well, wait, it's a mixed bag. Some of these medications cause metabolic harm. They cause weight gain. They cause diabetes. They cause all of this stuff. And we actually know that. All of these different psychotropic medications have been studied just in terms of their impact directly on mitochondrial electron transport chain. And they are influencing mitochondria. And some of them are improving it, some of them are decreasing it, and some of them it's a mixed bag. And the complexity of why would that work? This was actually the hardest problem I faced when developing the theory that I proposed. Because I really do know antipsychotics can reduce psychotic symptoms and sometimes put them into remission for some patients. That is really true. It really is true. And I really struggled with how does this make sense? Because at the same time, they're gaining weight. And it gets complicated, but one of the consequences of mitochondrial dysfunction is that a cell can become underactive. So it just doesn't have enough energy to work, and that's what most people think is probably happening. But paradoxically, cells can also become hyperexcitable. And it's that hyperexcitability that helps us understand why would a drug that reduces mitochondrial function, that impairs mitochondrial function, why would that reduce symptoms? It is reducing symptoms of hyperexcitability, which for some people can be life-saving. The challenge is that we are likely making those cells more vulnerable over time. And if that was true, what would that mean? It would mean that when I put somebody on an antipsychotic and keep them on it, they will be much, much more likely to develop a chronic disorder. They will be much more likely to develop new psychiatric disorders like OCD and substance use and all sorts of other things. And they will be more likely to develop all sorts of metabolic disorders. And they will be more likely to die an early death. And is any of that true? Tragically, all of it is true. So let's be a little more hopeful now. Can a metabolic treatment play a role in treating mental illness? So let's go through metabolic medications. Oh my God, I'm way behind. So statins, calcium channel blockers, metformin. So if metabolism is really driving it, if you treat metabolic symptoms, can that play a role in mental illness? Yes. Including SGLT2 inhibitors, including GLP-1 receptor agonists. I don't know if you all know, these are like all the rage now. These are a diabetes drug. It's a diabetes drug. Well, now nobody even knows that it's a diabetes drug. It's a weight loss drug. It's a weight loss drug that everybody wants. Well, guess what else? People are saying, oh, it treats depression. And oh, it's even good for addiction and substance use disorders. And we've got clinical trials underway already. So wait a couple of years and we're going to hear how Ozempic for whatever ails you. Ozempic for whatever ails you. But what about diet? Can diet play a role? First and foremost, I just need to say, dietary interventions are going to be different for different patients. We need personalized nutrition plans, at least with the patients I'm working with. Doesn't mean that CrossFit needs personalized nutrition plans for everyone. The CrossFit nutrition plan is great for a lot of people and fits the bill for a lot of people. But there are patients who absolutely positively need to lose weight, but you can be metabolically healthy because you're anorexic or because you have severe depression and cancer at the same time and you're emaciated. And that person needs to gain weight in order to restore their metabolism. Some people have nutritional deficiencies. If you have pernicious anemia due to an autoimmune disorder, B12 deficiency due to an autoimmune disorder, somebody needs to figure that out and treat it. You might need B12 shots. Not many diets are going to fix that. We might need to remove allergens, toxins, chemicals. There are healthy diets, gut microbiome. That's a whole talk unto itself. And more importantly, some dietary interventions can change metabolism. So the Mediterranean diet has been studied in a couple of studies. Sure enough, it can be helpful for clinical depression. 32% remission rate versus 8% remission rate in the control group. But one of my claims to fame is ketogenic diet. So I think all of you know what a ketogenic diet is, right? Does anybody not know what a ketogenic diet is? Okay, so you're too embarrassed to raise your hand. So ketogenic diet, everybody knows it as a weight loss diet. It's actually really good for type 2 diabetes. It's great for type 2 diabetes. It's been around since the 1800s for type 2 diabetes. But I am particularly interested in the ketogenic diet because it is an evidence-based treatment for epilepsy. And we use epilepsy treatments in psychiatry all the time in tens of millions of people. So, how does a diet stop seizures? We can't say this is the healthy diet. This is actually an intervention. So an intervention that restores your health is healthy. I'm not saying it's not healthy, but that's not the way I think about a ketogenic diet. And that's not the way I want any of you to think about it. I want you to think about it as a metabolic intervention for people who are metabolically impaired. And in fact, we know more about the science of the ketogenic diet than we do, and its effects on the brain, than we do any other dietary intervention. So the ketogenic diet changes neurotransmitters, reduces inflammation, changes hormones, changes insulin signaling, glucose, all sorts of things. But key and central to my thesis, it improves mitochondrial function through the process of mitophagy, which is getting rid of old and defective mitochondria and replacing them with new ones, and mitochondrial biogenesis, which is the production of more mitochondria. What that means is that when people are on a ketogenic diet for a year or two, their cells will actually have more mitochondria, and those mitochondria will be healthier. And in fact, when people use a ketogenic diet for seizure control, they can often go off the diet after several years and maintain the benefits of the ketogenic diet. So if they can put their seizures into remission, not everybody can, but if their seizures completely stop, oftentimes they only need to do the diet for anywhere from 2 to 5 years. They're able to stop the diet and their seizures never come back. And Charlie of the Charlie Foundation fame, for those of you who know that organization, he was on the diet for about 5 years and has never had a seizure since and is not on a ketogenic diet anymore. So does it work? Well, this research is actually from none other than Nora Volkow, the director of the National Institute of Drug Abuse. The ketogenic diet for alcohol use disorder. So we know that, again, people are like, alcoholism, what the hell does that have to do with a diet? Well, alcoholism is associated with brain glucose hypometabolism. Actually, all addictions are, because addictions are usually to toxic substances that are impairing your brain metabolism. And so Nora Volkow has been on this search for over 10 years. And so they recently did this study. They admitted a group of alcoholics to a detox unit. Half of them got a ketogenic diet, half of them got the standard American diet. The ones who got the ketogenic diet only needed about 50% of the benzodiazepines for their detox. Despite getting half the medicine, they had fewer withdrawal symptoms anyway. They reported fewer cravings for alcohol, even though they're not getting benzos, not as many benzos. They did brain scans, they had improved brain energy metabolism, and they had reduced inflammation in their brain. Schizophrenia, bipolar, and depression. I've reported cases of people with long-standing schizophrenia and schizoaffective disorder who have put their illnesses into full and lasting remission off of antipsychotics. The longest case that I'm aware of was an elderly woman. She had had schizophrenia for 53 years. It wasn't faked. She was in and out of hospitals, was a ward of the state, had people treating her, multiple suicide attempts, hallucinations and delusions. She put her schizophrenia into remission after trying Eric Westman's weight loss diet at Duke and got off her antipsychotics and lived for another 15 years, symptom-free, medication-free. This was a clinical case series. Patients with treatment-resistant bipolar, depression, and schizophrenia admitted to a French hospital. 31 patients began. 3 of them couldn't do it, so 28 completers. Of the people who were able to do the ketogenic diet, 100% had at least some improvement in symptoms. But get this, 43% achieved clinical remission. That doesn't happen with any current treatments today. They weren't getting exercise, by the way. Who knows what exercise might have done to augment this. 64% of them were discharged on less medicine, and oh, what a nice side effect of a treatment, 96% lost some weight. This is a 6 to 8 week trial of ketogenic diet for bipolar disorder. 20 patients completed it. One of the biggest complaints is these mentally ill people, they can't do a diet, Chris. They're not gonna stick to a diet. 91% of daily ketone readings were positive. When you are fighting for your life, when you are fighting for your sanity, you can do a diet. You really can. You need somebody helping you and supporting you and educating you and picking you up when you fall off the wagon. Maybe going to your home and raiding your refrigerator for all those foods that you're not supposed to be eating. They didn't do that in this study, and they still got 91% daily ketone readings. These patients can do a diet if you give them the chance. What happened? They lost some weight. Their blood pressure came down. Their brain metabolism improved. And look what happened. Their symptoms of bipolar disorder all improved in a linear fashion consistent with their compliance with the diet. The higher the ketone levels, the better the symptom improvement. And then this study, which actually got national and some international headlines, ketogenic diet, treatment-resistant bipolar and schizophrenia, 21 participants for 4 months. 79% of the participants had a clinically meaningful psychiatric improvement. Of those who came in with metabolic syndrome, 100% reversed it. Nobody left this study with metabolic syndrome. On average, they lost 10% of their body weight, and they too noticed a trend. The greater levels of adherence, the greater levels of ketones, the greater the clinical improvement. So I am really honored to be now running a metabolic and mental health program at McLean Hospital, but this is a global effort. We have research studies at Harvard, at Oxford, Hopkins, Stanford, around the world. And with that, I thank you.